Good evening, everybody. This is going to be a new experience for me to be in this hybrid system of having a conversation with you guys and you guys. I did put together a handout that I hope you all got. And that QR code on the first page is going to give you guys a short summary on the use of tenecteplase. So you can look at it at your own leisure. Can we begin with a first portion then? So on the first page that looks like that, okay, we're going to take you through the thought process of what happens, what we should be thinking about when we encounter a patient with an acute stroke. The patient arrives with stroke-like symptoms. At that point in time, a quick way of assessing the patient has been FAST. Okay? But now, more recently, because of missing a group of patients, the BFAST started to get more popular and has gained momentum throughout the country. So FAST is face droop, arm droop, speech difficulty, and time, as in time is brain. The only difference between FAST and the Cincinnati scale is that FAST includes time, and the Cincinnati stroke scale does not. Otherwise, they are the same. But then, as we have grown, you remember, we started using alteplase, IV medication in the acute setting for acute stroke in 1996-ish, thereabouts. So we have learned a lot in that period of time, and then endovascular treatment came along. Alteplase is now being faded out, and tenecteplase is taking its place, and also we have learned more about the strokes that we have missed, and we shouldn't be missing if we know what we're looking for. So in the BFAST, the B stands for balance, the E stands for eyes. And remember, for balance, we have three systems that navigate us around the world. Okay? The eyes, the ear, and our proprioception. The eyes are a key element of our balancing system, but sometimes it happens that a patient can have a stroke on the non-dominant side of the brain and be completely blind. And the patient will not complain to you because they have anosognosia. They have complete neglect of the complete hemianopsia of the world. If you're expecting the patient to tell you, hey, I cannot see over here, you are missing the boat already because the patient cannot tell you. In the extreme version of it, when the patient is completely hemiplegic, okay, and numb on the non-dominant side of the body, you grab their hand and you show it to them in the visual field that they can see, and that's not their hand. And they cannot tell you, they will not tell you that they are weak anywhere. They will not recognize that deficit. And that deficit at its maximum, as I am describing it to you, completely numb on the left side, completely paralyzed on the left side, completely blind on the left side, the patient is not complaining to you about it. The family, somebody else, the observer, is noticing that the patient cannot move. And that is what alerts the bystanders to bring the patient to the hospital. But it could be partial also, especially thinking about the eyes. Okay? It was actually just this week, we did get a patient with a complete PCA stroke on the non-dominant hemisphere, no complaints whatsoever. And she could not see half of the world. So if that patient is walking, okay, she's going to have difficulty keeping herself balanced. So balance is an important element from the vision perspective. Also from the proprioceptive perspective, the sensation perspective. If the patient doesn't know where their body is and they try to walk, assuming that they could still walk, okay, they may be able to not perceive, they may not be able to perceive where the body is in space and time, and then have a tendency to fall. and may not complain about it also. So anosognosia is an important element of the acute stroke patient, and we are not completely looking for it except when we do the NIH stroke score. But generally, in the emergency setting, that's not something that people are aggressively looking for. We're missing something there, and it is in meetings like this where we can elevate the level so that we can all be more attentive to these nuances and the details and the patients that could still be benefiting from the acute treatment of acute stroke, even though they may not complain about it. If the patient loses vision on the left side, they will not complain about it, but the eyes now are going to be deviated to the opposite side. Now, if that's all you see, the patient comes into the emergency room and the eyes are deviated to the left side, to the right side, and they cannot move them to the left, you can take it to the bank. That is a large stroke. That's probably a full hemispheric stroke. If there is one symptom, okay, or one sign that will tell you that the patient has a large stroke, is the eye is force deviated to the opposite side. So therefore, the importance of the B and the importance of the E in BFAST to fine-tune and capture more of these patients that could benefit from the acute treatment of for a stroke. So the patient arrives to the emergency room, and the first thing that we need to do is the ABCDs. ABCDs come before the N, the neurological deficit. Is the patient able to breathe? Do they have a vital signs? And once we have established the airway is patent, the blood pressure is adequate, then we move over to the rest of the neurological evaluation. Ideally, the blood pressure should be 120 to 220. 220 is the maximum blood pressure allowed by the guideline, and when you look at the first portion of the guideline, 120 is actually the other limit. You should have a little bit of a hesitation, something not fitting right, when somebody says, keep the blood pressure less than 160. How about if we were to say that, keep the heparin more than 60? Would you have a hesitation about that? You want a corridor, okay, between 60 and 80 on that heparin. You want that navigation, okay? And so should be the blood pressure in acute stroke, okay? So 120 to 220 is the lowest number and the highest number with the patient flat, okay? That is the resuscitation position. It's not head down, maybe flat with the legs up, but the trunk flat. Okay? Do not try reverse Trendelenburg the patients. Okay, so head at the level of the heart, allowing the entire strength of that left ventricle to push blood into the brain and around the clot to open up the collaterals and make the area of the stroke smaller. You want that penumbra to get smaller as quickly as possible. A phenomenon that I encounter, and you should have seen in your emergency room practice, the EMS brings the patient at 45 or 90 degrees on their stretcher in the ambulance, and then they go to the CT scan, they go flat, and then when they come out of the CT scan, they are better, just because we lay them flat. Because gravity is stealing the blood from the brain. You're pumping upstream. So for every centimeter, because of the specific gravity of the blood, for every centimeter above the aortic valve, you're going to lose 0.7 millimeters of pressure. So if you are 10 centimeters, you lost 7 millimeters of pressure. If you are 20 centimeters, you lost 14 millimeters of pressure. So if the patient is sitting up and the brain, let's say, is at 30, and you lost already 20 millimeters of pressure, you are already at 100, at 100 if the patient is sitting at the level of the brain. That's why in the neuro ICUs, when things are very active, trying to maintain the cerebral perfusion pressure, we zero the blood pressure, the invasive blood pressure, not at the level of the heart, but at the level of the tragus, just like where we zero the EVDs, so that we know what pressure, what arterial pressure the brain is actually seeing. So the more than 220 is dangerous. Less than 120 is also dangerous. The blood pressure is less than 120. Lay them flat. Give them a bolus of normal saline. Please not lactated ringers. Lactated ringers is a good resuscitation agent for sepsis. And that's it. You haven't found anywhere else where it is useful. Okay? So lactated ringers, in fact, the guideline, the consensus statement says use normal saline, do not use albumin, please, and do not use lactated ringers. If you're dealing with a neurological injury, you're using normal saline to resuscitate the brain. At that point in time, when you have the blood pressure 120 to 220, okay, then you are trying to get a little bit more information. Key pieces of information is, when was the patient last known to be at baseline? Okay. When was the patient last known to be at baseline? The question is not when was the patient found with a deficit, because that's not going to be actionable. If the patient went to bed at 10 p.m. and gets up at 6 with a deficit, last known normal is 10 p.m. And that's where the hours are counted from. You're also exploring at that point, what is the baseline neurological function of the patient? You're then going to have the modified ranking scale, and it is there in your handout, under the NIH stroke score and on the page with the contraindications. Okay. What is the modified ranking scale? How does this patient move around? Does the patient need a walker, a cane? Once you are using a tool to ambulate, you are already a 3. Okay, I mean, you're already a 4. And if the patient needs has motor disability and the patient needs help with their everyday life, that's a 3. And per guideline, once you hit a 3 or greater, you are not a candidate for endovascular treatment. And you're going to see as we go how that value is important on the decision on whether we need to do a CTA or not early on. Because if we're not going to consider the patient for endovascular treatment because the modified ranking scale is way too high, then there's no need to do a CT angiogram acutely. Maybe we need some imaging of the carotid artery tomorrow, but it's not an emergency anymore. The only test that we need for lab test, blood work, that we need for decision for acute revascularization, whether it's chemical or mechanical, is the glycemia. Get a point of care glycemia, get the NIH stroke score, and by then you have the NIH stroke score, the modified ranking scale, and it's so easy to get done, and actually has a meaning also when it comes to what we're going to be deciding, especially if the patient is found to have a bleed inside the brain, the Glasgow Coma Score. Glasgow Coma Score. You should, in Glasgow, Kentucky, you should get up in the morning, it's like a Glasgow Coma Score, I know that. So the patient is NPO, and the key here, I think, explaining to the family and the patient that we're doing that for their safety. Because if they are weak on one side of the body, half of the throat is weak. If they are numb on one side of the body, half of the throat is numb. And eating can compromise their airway. So it's a safety issue. We are going then, if we're in less than 24 hours after the last known normal, then we're going to do a plain CT scan. So if the patient has a stroke-like symptoms, then and we're in the first 24 hours, we're going to go then to the CT scanner. Here we're looking at all the other elements that we need to be doing, and in best practice scenario, the patient goes from the stretcher from the EMS to a gurney that can weigh the patient, and then to the table of the CT scanner. Now you have a weight that your nurse is already calculating, or the computer is already calculating what the dose of the tenecteplase place could be. Okay? You are not, thumbing it, like guesstimating or asking what is the patient's weight. You know the patient's weight. So the patient then goes to the CT scanner, and if the CT scanner shows a bleed, let it be intraparenchymal or extraparenchymal, subdural, suprarenal hemorrhage, then if there is a bleed, the patient does not need an emergency CT angiogram, especially if it is the more common type of intraparenchymal hemorrhage. Do not need a CT angiogram at that point. Everything ends, no tenecteplase, no endovascular treatment. If the bleed is in the parenchyma, the management of that patient is medical, only medical. There's no business to bring neurosurgery to see a bleed in the parenchyma. Okay. Bleeds in the parenchyma are medical. Neurologist should be the one managing all that. If the bleed is outside the parenchyma, suprarenal hemorrhage, subdural, epidural, and intraventricular hemorrhage, then neurosurgery can come in to do the evaluation and the additional diagnosis. So at that point in time, we stop in the CT suite, and we're going to evaluate the CT scan. If the patient has an NIH of 5 or more, no contraindications for tenecteplase, then we're going to give tenecteplase in the CT scanner. Once the tenecteplase is given, which is now a single bolus, you used to need 2 IVs for alteplase, because the alteplase was going to go for 1 hour in one vein, and the other vein was going to be the normal saline or whatever else you're going to use, the nicardipine or whatever else you were going to give in the other vein. So you needed 2 veins. Now tenecteplase is a single bolus. You go ahead and you give it 3 seconds, you're done. You have an IV to do whatever else you want with it. So it's easier in that sense. So if the NIH is greater than 6, first 24 hours, then the patient should get right there and then, without getting the patient off the scanner, a CT angiogram. So the key things here are less than 24 hours, NIH 6 or greater, modified Rankin scale 0, 1, or 2, and no bleed in the plain CT scan. The patient needs a CT angiogram to look for a large artery occlusion, large vessel occlusion, a vessel where a catheter could go in to retrieve the blood clot. So if there is no, the way we do it in the hospital where I work, we stop there again, and the neurologist, not the radiologist, we have the advantage of having that available. If there is no large vessel occlusion, then the patient does not need a CT perfusion. If there is large vessel occlusion, then we move on to the CT perfusion. And depending then on the size of the penumbra versus the core, if it is about 50%, okay, 50% core in relation to the penumbra, then the patient is a candidate for endovascular treatment. if we have a clot that we can go after within the vascular treatment. And we can go, the arteries in the brain, the main artery, for example, the middle cerebral artery, has generations. Every bifurcation is a generation. First, you have the main middle cerebral artery. It bifurcates those bifurcations, generally two, although they can be three, daughters. Those are M2s. So M1, the main one, M2, then those bifurcate again, those are M3s. So generally, we should be able to go get a blood clot out of an M2. And depending on the M3, if it is large enough, we may be able to navigate into there too. So this is more or less how this works. If the patient is in the hospital and the nurse finds that the BFAST is positive, so your nurses in a stroke center need to be well versed in the screening tool that you are deciding to use. You're going to use the BFAST, then the nurse finds that the BFAST is positive, the code stroke gets activated. And this whole thing then begins to happen. It's been a challenge. It's interesting how across the country, inpatient stroke actually takes longer to do than emergency room stroke. We're trying to figure that out, how to accelerate that process. But the key here is to identify the patient early and be able to move fast through the process. There are certain landmarks. The patient needs to have a CT scan done within 15 minutes of that call. So sometimes there's no time to wait for the physician to come to the bedside to assess whether they think it is a stroke or not. Sometimes you just have to move to the CT suite. And then they can go see the patient in the CT suite. That's, again, part of the stroke center work. In box number 2, then, if the patient is in the first 4.5 hours, we're going to consider the patient for IV medication, IV tenecteplase. So NIH 5 or greater, in less than 4.5 hours, no bleed on the CT scan, IV tenecteplase. If it is less than 5, if the stroke symptoms are considered to be disabling, and that's relative, right? Because if I have a concert violinist, okay, with a clumsy hand, that could be disabling. Okay? But if I have a retired individual that is, doesn't need that agility in that hand, it's non-disabling. It doesn't really affect their quality of life as much, their livelihood. So that patient may be okay without the risk of, the relatively low risk of using tenecteplase. So there is a little bit of a judgment call there. The goal is to get to the IV tenecteplase in less than 45 minutes. And once it is given, then the patient should have a certain set of vital signs every 15 minutes, and that should probably include an NIH stroke score. And document. The big challenge in that point is the documentation by the nurse of those vital signs. So sometimes creating a page that go back to the analog instead of digital to be able to track or even to have a little alarm clock that rings every 15 minutes or some other method. It's time to document, get this done and document. And in the dollar store, and I know you have dollar stores here, they sell these kitchen timers. So what I do is I buy the kitchen timer, $1.25, put it on 15 minutes, okay, and crazy glue the buttons so they cannot change the 15 minutes. So, but they have to activate it every time. But it's one way of trying. There are other codes that you can create for the phone, etc. But that is a simple analog way of trying to solve the problem of the documentation and taking the vital signs. So the patient that is in their acute critical period should be flat, well hydrated with normal saline, with a blood pressure 140 to 180. We know that that is the sweetest spot in the first 24 hours, 140 to 180. Less than 140, the neurological outcomes start to dwindle, and more than 180, the neurological outcomes start to dwindle. So 140 to 180 is your goal. 140 to 185, somewhere there. Okay, it doesn't need to be precise, but that's where you want the patient to be living for the next 24 hours. Next box, please. So if we're in less than 24 hours, let's say we're between 4.5 and 24 hours, the patient is not a candidate for tenecteplase, but the NIH is 6 or greater, the CT scan does not show a bleed, and the CT angiogram has a blood clot in a large vessel, in the large artery, then that patient is a candidate, emergently a candidate for endovascular treatment. And that patient then should be flown out of here to your favorite place to get that done. And the idea is to have a growing puncture in less than 90 minutes from arrival to the door. Okay, time is ticking. Okay, one quick word about tenecteplase before we move on to the mechanisms. Tenecteplase is essentially alteplase, but they tweak a couple of the amino acids. Now, instead of having a very short half-life of 2-3 minutes, has a 20 minutes half-life. So the risk and contraindications are the same. It may be a little bit safer than alteplase, and it's easier to give as a bolus, because you give a bolus and now you have 3 half-lives, 60 minutes, just what you needed, just what the doctor ordered, 60 minutes of IV thrombolysis. That with alteplase, you have to maintain an infusion because the half-life is so short. So in our system, we have completely moved away from alteplase. Now we are like, what is that? Okay, it's all about tenecteplase. It's so much easier to use, and also easier for the EMS to transfer the patient with tenecteplase than with alteplase, because now they don't have an infusion to be dealing with. So an acute ischemic stroke means that something clogged the artery in the brain, and that piece of brain became ischemic. And with that ischemia, the symptoms began and were maximal at onset. The question then, if women are from Venus and men are from Mars, where are blood clots from? Okay. Blood clots come from 3 places. Okay. The pipes, the pump, and the plasma, in that order in people older than 55. So that order that I'm putting there in front of you in people older than 55. 55 or less is considered young in the world of a stroke. Yeah, not me anymore. So the pipes, and we have 3 different pipes. We have the large pipes, the small pipes, and the veins. Okay. We're not going to talk about the veins. We're going to talk about the big artery or the smaller arteries. So we are then going to explore if the patient has a carotid stenosis, and I included the algorithm for carotid stenosis, fully updated with the latest guidelines, okay, for carotid stenosis. It's in your package. If the stenosis is 60 to 99%, and the patient has symptoms on that territory, that patient should be operated on probably within the first 2 weeks. Okay. And that's the only place where we have a surgical treatment. If the arterial stenosis of the larger arteries in the brain is present, there is an MCA stenosis. There is a PCA stenosis. There is a basilar stenosis. There is an ACA stenosis. There is an intracranial ICA, intracranial carotid artery stenosis. The treatment is all medical. You don't need it to be imaging the intracranial content if the treatment is not going to change your treatment. Okay? The treatment is going to be, or we're going to talk about that, but it's going to be the same, because you're not going to send somebody to do a balloon angioplasty or deploy an intracranial stent in there. We can do a carotid artery, a carotid surgery, endarterectomy above the stent. The endarterectomy is always a little bit better than the stent. So if it is on me, you do me a carotid endarterectomy. Okay. If I cannot have a carotid endarterectomy, and there are some criteria that are outlined there, then a stent is the next best thing to do. So in that order in which they are listed there also, under the pipes, CTA is the best non-invasive test for imaging carotid arteries. The same amount of contrast, 80 cc's of contrast, whether you do neck or brain or both. Do both. Okay? It's a little bit more radiation, it is true, but that way, just get it done. Okay? If you're going to do a CT angiogram, just do both. Then the next the second best is carotid ultrasound. Okay? It will focus only on the neck, which is where you're going to make a surgical or non-surgical decision, because everything else is going to be medical. Then MRA with contrast. Okay? If you think you look good doing an MRA, I'll tell you, you are going to look better not doing an MRA. Okay? MRA is not really the best test, especially if it is not done with contrast. So MRA with contrast would be the distant number 3. The next one is MRA without contrast. And then if you have a 3 Tesla machine, in the 3 Tesla machine, if you don't have it, do it in whatever you got, 1.5, 0.75, whatever you got, without contrast. Some patients with chronic kidney disease cannot have the contrast, the MR, the gadolinium. So you may be, and they cannot, and the carotid ultrasound wasn't good quality because of their anatomy or whatnot. So that's the order of thinking. The number 2 source of blood clots is the pump, the heart. And by far and away, the most common etiology of the clots from the heart going to the brain is atrial fibrillation. Okay? And you don't need a cardiac ultrasound for that. You need your finger connected to your brain to feel the pulse and say, oh, the irregular. Done. Okay? And then, since the patient is in the emergency room or in the hospital, just do a telemetry and EKG. Cheap, done, atrial fibrillation. Okay? At that point in time, do I care if there is a blood clot in the heart or not? I don't care. Okay? So doing a cardiac ultrasound to go, is there a clot in the heart? How is that going to change what you're going to do? The patient already has a full indication for anticoagulation. What you're looking for now is a contraindication. You're not looking for an indication anymore. So then from the stroke prevention perspective, the patient has a TIA or a stroke and is an atrial fibrillation anticoagulation. Don't need a cardiac ultrasound. Now, you may need it to figure out what the etiology of atrial fibrillation is. Okay? If it is a de novo atrial fibrillation, but if it is, the patient is already known to have atrial fibrillation, you don't need a cardiac ultrasound. The next thing is severe CHF, defined as less than 25% ejection fraction. Many of these patients already are known to have severe ejection fraction reduction. And some people will argue, well, if you have less than 25%, then you probably need to be considering anticoagulation. And even more so if you have decreased ejection fraction R in atrial fibrillation. Okay, so that is a double whammy. So if the ejection fraction is 30 or greater, we're not going to anticoagulate them. Okay, so how can you find that out? There are several ways. Clinically, the NIHA classification, the New York Heart Association. Hey, sir, how far can you walk at your own pace? Okay, or hey, doc, I can only go to the restroom and I am short of breath. Okay, in NIHA 3. Or I'm short of breath at rest, NIHA 4. That ejection fraction is less than 25%. If the patient says, you know, doc, yesterday I was running half a marathon, what is the ejection fraction? It's normal, okay? Okay. So the other point here is the issue of the paradoxical clots. If you say that the patient has a PFO, which a number of us in this room have, okay, but how often do they become symptomatic? Very, very infrequently. You are invoking a paradox. You are invoking that the patient got a blood clot in the vein that went through the hole in the heart and went up into the brain. Very small number. And the only ones that we're going to be considering for closure are less than 60 years old. So if the patient is 60 or greater, I don't care if they have a hole or not. We're not closing them. And it's not going to change what we do either. Now, if you find a DVT, you need to anticoagulate them. That's a different story. Now we are moving more and more towards point-of-care cardiac ultrasound. Okay, and to do with your little ultrasound probe on your phone, okay, a cardiac ultrasound, I mean, that takes you about 10 seconds or less, okay, to put the probe there and look at the heart, and that counts. You put it there and you find an ejection fraction of 10%. Let me see if I can show you the last one. Okay, here it is one. See, 10%, 15% ejection fraction right on my phone. I mean, this takes less than 10 seconds to do, okay? And you do not need, the full shebang of, what is the jet through the mitral valve. Don't care, okay? And then a large anterior wall MI. If the patient has a humongous acute stroke, acute cardiac stroke, acute heart attack, that will drop the ejection fraction, and the inflammation of the healing will also be thrombogenic. So the stroke tends to occur 2, 3, 4, 5 days later rather than just acutely. But that's also a little bit of a different story, because how often do we see large anterior wall MIs? Not very frequently in the course of a year. Typically, they are non-Q wave MIs and something smaller, because we're getting better at prevention in general. And then the last one, and the least probably, is the plasma. How is that blood working? Is that plasma too thick? Do they have too many platelets? Is there too many red blood cells? Is there too much protein that makes that blood sluggish to move? Okay, so and we're going to be getting a CBC on this patient, so we already are going to have an idea of if polyglobulia or polycythemia vera, if both platelets and hematocrit are elevated. And then if everything is starting to look negative, then you may want to take a look at the proteins in the plasma and do a protein electrophoresis to see if they have a multiple myeloma causing the problem. Okay, that is now the second tier of the diagnostic workup. But by far, once you're outside of the CBC, by far probably the more common would be the antiphospholipid antibody syndrome. And how often do we see that also? Not very. In the course of a year, a handful, 1, 2, single digits, okay, at the most. So very infrequent. So, and if you're invoking then one of these procoagulant thrombophilic states in the plasma, you're saying that 90% of them are venous. Take them all, lump them all together. Okay, 90% are venous already. Factor V Leiden, venous. Okay. So you're saying it's a paradox. So there is a right to left shunt somewhere, either cardiac or in the lungs. If you're saying it is antiphospholipid antibody, that's the most common arterial or both venous and arterial, and that's less than 10% of that group. So it's even a smaller fraction. And once you get the PTT and the PTT is prolonged, you say, maybe I do have a lupus antibody here. And then you start exploring that. But how often does that happen? Again, we're talking about frequency. So when it comes to prevention, health illiteracy, if I can pronounce that right, okay, health illiteracy is a risk factor for stroke and recurrent stroke. And we are in charge of fixing that. So the importance of educating the patient on the risk factors. It's the first on my list of prevention. Okay. And trying to engage these patients. Some of these patients may not want to be engaged. That's true. Okay. But for example, if they smoke, we need to ask them to stop smoking. I don't tell them, would you please stop smoking? I direct them, stop smoking. Okay. Who wants to take a chance here? And how many people do you need to advise, smokers? How many smokers you need to advise for one to stop smoking? Okay, sort of a number needed to treat. 1 in 100? Anybody? Okay, we have decades of evidence.
I'd say in the clinic it's 1 in 20.
Yes.
However, I'd say if they're sitting on the table, it's a lot. That depends on your population.
Yes.
If they've had an MI, it's going to be 90%.
So the number is in the low double digits. If it is a physician advising, it is somewhere around 14. If it is a nurse practitioner, it's about 18. So the number is somewhere there, which is better than aspirin, which is 22. So you need to give, for the composite of stroke, peripheral vascular disease, and heart attack, you need to treat 22 patients for a year to save 1. But for smoking, you need to do about 16. Which one is more powerful? That gives you the right to flex, And no side effects. Okay.
And that risk factor is 20 times the weight of the other risk factors.
Yes, it's a heavy.
It's not the same weight.
It,
I'm
it,
not going to do my diabetes, my cholesterol, I'm not going to do this. It's 20 times the weight of the other factors.
Very good point made there, yes. So, stress management. People that are stressed, okay, our risk of stroke is almost double just because of the stress. Okay? So stress management, what are we doing to help the patients manage their stress, not prevent their stress? If those of us that may think that prevention is the way to go, we are definitely not understanding what stress is. Stress is what the world is doing to us. It's not what the world is doing to us, it's how we are reacting to what the world is doing to us. Therefore, being our reaction, we can learn to manage it. So it's about managing stress. It's not about preventing stress. The loneliness. Okay, my unit, we're moving to make the neurofloor a loneliness management prevention unit, so that everybody that comes in there, we're actively asking about loneliness. In fact, one of the things we're trying to do is we're partnering with one of the animal rescue places, because it is very difficult to place an older cat. Once it's there, the older cats are difficult to place. But the older person that can be paired with an older cat, which is easier to maintain, and Mars, the company that makes the kibbles and animal stuff, which is based in Nashville, that's the headquarters, okay? They are then willing to provide a 1-year supply of food and toys for the cat, and the the rescue is has a compromise of being there to offer free veterinary care for the cat in case the cat gets sick. And if the individual gets to be hospitalized, then the cat goes back to the rescue. So so loneliness is an important issue, totally underestimated. Okay. So my point here is that there are a lot of things that are not directly a medication that has a lot of power in the quality of life of the patient, in the well-being of the patient, and it is not just about medications. Medication-wise, here at the bottom, the very lowest line there. Okay. If the patient has a TIA or an NIH stroke score of 4 or less, the patient will get dual antiplatelet therapy. I am stuck with Plavix and aspirin, and anywhere between 3 weeks and 3 months. So I just default to 4 weeks, right there in the middle, easy to remember number. Then dual antiplatelet therapy at 30 days, or whatever time you decide, 3 months, 3 weeks, whatever, you drop one of them, whichever one you want, and you stick to single agent. If the stroke is large, okay, or you catch them more than 48 hours after the stroke, then it's a single agent. So you have to begin the dual antiplatelet therapy in the first 48 hours. Questions? So dual antiplatelet therapy for minor strokes and TIAs, initiated in the first 48 hours, and after the period of time that you choose, then single agent indefinitely, unless there is a contraindication. Then a statin treatment. I don't care anymore about the cholesterol level. Okay. Although the guidelines, the Joint Commission has it that we need to be, if the patient has a plaque, whatever cholesterol they have, if it looks normal, it's too much. Okay. In the 2017 lipid guidelines, cholesterol guideline, pretty much they said, forget about this levels, okay? And we keep on doing it. In the same way we keep using this useless stethoscope, okay? We keep on ordering a lipid profile. No, even if the patient has normal cholesterol, and let's say they don't have a plaque but they have a stroke, if they are on the Lipitor or the statin of your choice, they will do better, sooner, and for longer if they are on the statin medication. And if they have another stroke, it will also be smaller and less disabling. So it is beyond cholesterol. It's inflammation and the other pleiotropic effects of the statin medication. And for medication prevention-wise, management the chronic arterial systemic hypertension. Notice I say chronic, not the acute one, because cocaine, deal with that. The risk is the chronic arterial, not venous, systemic, not portal or pulmonary, and hypertension, chronic arterial systemic hypertension. And the treatment for that is manage your diet, lower that salt intake. There is some incredible trial that was published for about a year and a half ago, showing that if the patients mix 25% of that salt supplement, the potassium chloride that you buy at the grocery store, and you mix that 25% to 75% regular salt, okay, and that's what you used in your food, your risk goes down. Okay? And this was a population large study. Okay? And all these developments take time to catch on with us and the population, but that is another avenue. And the best diet seems to be the Mediterranean style diet, followed by the DASH diet, which is very similar to the Mediterranean, but less salt, and then the vegetarian diet in that order. Okay, just like in Glasgow, right? Just like in Nashville too, just like in the world. Okay? We should be eating more Mediterranean style diet because of the benefits, including a slowing cognitive decline, not only stroke prevention. And then if the patient meets criteria to go to rehabilitation, inpatient rehabilitation, they should go. The patient goes to rehabilitation will get better faster, higher, and the gains are going to be more sustained, measurable, 10 years later after the stroke. I challenge you, give me any other intervention you got that will protect you 10 years later after you have had a stroke. Bring it on. Okay? So not only that, because the patient will be more active, the risk of a stroke also goes down by having been in acute rehabilitation after a stroke. So hence the importance of getting that done. So I think we covered all the main items that we had. It's 7:05. So questions?